So I will provide some information. Well, first recap all the great learning that you've had throughout the series, and then talk about where we go from here as relates to health-related social needs and its impact on hospitals and community-based organizations organized into delivery systems. Next slide. So first, in terms of the recap, I want to circle back to the inpatient prospective payment system rules, which really started the process where hospitals had to begin considering a process to screen for health-related social needs, and then also talk about the physician fee schedule and its impact. Next slide. So as you recall, in the inpatient prospective payment system rules, it required hospitals to begin screening for health-related social needs for any person over the age of 18 admitted to a hospital and has to be over 18 on the day of the admission. Initially in FY23, it was a voluntary process, which then moved to mandatory for FY24, and then will begin penalties for FY25. For hospitals that do not report. And so it does require this screening for social drivers of health, and then a reporting on the percentage of the population that was screened, and separately the percentage of the population that screened positive in 5 domains. Next slide. So first of the measure was that the facility's commitment to health equity. This is part of a broader health equity agenda where there's multiple things, policy perspective, to drive equity, and that equity also has a key financial impact, because improving health with a focus on equity also reduces costs and improve outcomes for the whole population. So first domain is establishing equity as a strategic priority, data collection to include demographic data on health-related social needs and other things, the analysis of that data, incorporating that into a broader quality improvement strategy, and having leadership engaged. So an example of that is looking at things like readmissions, and then the overlay of those readmissions, persons who had one or more social needs, and are there differences in the readmission trends based on the demographic data or other factors? And then are there things that we as a facility could do to better address the needs of the population when there are differences in the outcome data based on some of those demographic trends? That's an example of measure 1 of facilities' commitment to health equity. Next slide. So the measure 2 is the screening for social drivers of health. So as a repeat, there's 5 different evidence-based domains for health-related social needs. That includes food insecurity, housing, transportation needs, utility difficulties, and interpersonal safety. So the measure is to screen and then report the results of the screen in each of those individual domains, where each domain is a separate report as part of the broader quality measures. And the intent of that measure is to promote adoption of the screening. This first measure is just the screening activity. It doesn't capture data around the outcomes of the screen. That is a separate measure. And so the desired outcome is that there's this increased level of screening. And then ideally, as we screen and identify needs, there are linkages between hospitals and community-based organizations that have organized into delivery systems to address identified needs, particularly when those needs are impacting patient care or the ability to transition people back to community settings. Next slide. Then separate from that is the screening for positive rate for social drivers. And this requires a reporting of not the results of the screen that are positive. And that is also reported in each of the 5 domains, where the intent of that measure is to capture the magnitude. So one is screening activity, and then separate from that is the impact or magnitude of the health-related social needs amongst the people that we serve. So looking at trends in the data, where we may identify that the trends are showing there's a significant population that maybe has food insecurity or housing insecurity, and then matching community resources to see, do we have resources to address those needs with a correlation on its impact in clinical quality measures, whether that be things like readmissions, length of stay, and other activities. Next slide. So with all of this emphasis on screening and identifying the outcomes of the screening, the Centers for Medicare and Medicaid Services for calendar year 2024 established new payment policies to specifically create a pathway for reimbursement for addressing health-related social needs, which is the Community Health Integration Codes. It is a Part B benefit, specifically for persons who have a health-related social need. I want to point out that in the list of eligible services under Community Health Integration, CMS specifically listed transitions of care as an activity when a health-related social need impacts the ability of an organization to transition someone from an acute care hospital to community or an institutional site back to community, that you can leverage this benefit as a payment pathway for the labor to address the health-related social needs. Separate from the community health integration is screening for their needs, which is the social determinants of health risk assessment. All of these are Part B, as in boy benefits, and principal illness navigation, which is for persons who have a high-risk condition that's expected to last at least 3 months. Examples of that was dementia, heart failure, diabetes, and other factors. And then lastly, principal illness navigation peer support, which, as a reminder, is for persons who have a behavioral health or substance use disorder, and it's specifically a benefit for the labor of trained peer support workers. Under the fee schedule, CMS created a pathway for Part B providers to contract with community-based organizations. CMS specifically listed that in the rules and gave examples of community-based organizations that could be considered partners. We kind of pointed out that whether you have an integrated health system or health systems that have clinical sites that are delivering outpatient care, a partnership between the inpatient side and the outpatient care delivery, whether that be a resident clinic, a transition clinic, or an outpatient clinic that's part of a broader medical group that's affiliated with the hospital. Those are our pathways to trigger reimbursement to support transitions of care, particularly addressing health-related social needs or navigation needs that are impacting a discharge from the hospital or an observation stay. These codes can be built concurrently with transitional care management and other care management billing codes, such as chronic care management. So it really creates a pathway to sustain a whole person care model where their social needs and addressing those social needs is directly reimbursable as part of a broader whole person care strategy. Next slide. So now that we've recapped all of the information regarding requirements for hospitals to screen, reporting the results of positive screens, as well as highlighting the payment pathways under Medicare Part B, we had not talked a lot about options for Medicaid. And as a hospital is repeating that requirement to screen for health-related social needs for all persons over age 18 will include the Medicare population, but obviously persons that are not Medicare eligible. And so we've also wanted to point out options under Medicaid, and then also at the end recap some opportunities under Medicare Advantage. So some of the options under Medicaid creates a pathway, but it is dependent on flexibilities that the state has elected to choose under additional flexibility that's offered from the Centers for Medicaid and CHIP services at CMS. Next slide. So if you're familiar with that term 1115 waivers, in many states, and you see all of the states that are listed on the screen, and these states are either have an existing 1115 waiver or they have a pending application, or some states have an approved 1115 waiver and are modifying that. So they have a current approved, and then they have pending modifications to their existing 1115 waiver to provide other services. So under the increased flexibility on the 1115 waiver, the Centers for Medicaid and CHIP Services is creating a pathway for states that want to elect as a healthcare benefit that would also roll through to the managed care organizations to address health-related social needs as part of Medicaid. Some of those health-related social needs provisions that can be covered under an optional 1115 waiver includes things such as housing supports, nutrition supports, and other services. So if you think about hospitals are ramping up their screening, identifying many persons who have health-related social needs, and now under Medicare through billing for community health integration and other services, and under Medicaid with expanded flexibility under 1115 waivers, it creates a pathway for reimbursement for deploying interventions to specifically address identified needs in the hospital. So that could be part of the toolkit or the decision tree. As we're screening and ramping up screening, we now have a positive. Does this person, are we operating in a state that has an existing 1115 waiver? Does this person have Medicaid? Yes or no? Is the need, the social need, included in our state waiver? And who are those community partners that can bill or receive reimbursement under that 1115 waiver? And then having that list of those options available to our discharge planners and case management team so that they know how best to facilitate the care as we're ramping up the screening for social needs. Next slide. So I want to go through some examples of Medicaid state innovations where the state Medicaid authority has decided to use the 1115 waiver process to incorporate benefits to address health-related social needs, and then just point out the overlay between persons that are admitted to an acute care hospital or have an observation stay in the emergency department. And now we've identified that they have social needs, health-related social needs. And if that person that's admitted also is enrolled in Medicaid, depending on your state waiver, there's additional options to support the services they may need to facilitate that transition to a community setting. So highlighting in Arizona, the Arizona Healthcare Cost Containment System Housing and Health Opportunities Demonstration and Targeted Investment 2.0 program. So in Arizona, under their 1115 waiver authority, they decided and got approved for enhanced and expanding housing services and interventions to address members who are homeless or at risk of becoming homeless. So now this person who's admitted to the hospital, who has housing insecurity and is enrolled in Medicaid, if I'm a hospital in Arizona, I want to understand the network of organizations approved under the 1115 waiver to provide that expanded housing services and interventions. And then once we identify persons that are homeless or at risk of homelessness that are in my acute care hospital, I would link to those programs as part of my discharge planning process, knowing that there's a payment mechanism to support that expanded housing services that is complicated based on an admission. For hospitals in California, the CalAIM 1115 waiver, in their waiver, they included a range of community supports to include recuperative care and short-term post-hospitalization housing. So now this person who has Medicaid, who may have had a surgical procedure or other things, who was homeless or had a history of being unhoused before they're admitted, now using this waiver authority, there could be short-term post-hospitalization housing to facilitate a safe discharge, but that would require the hospital engaging in contracting with community-based organizations that are participating in that waiver, or identifying community care hubs, because California is another state where they're actively encouraging the growth of community care hubs to implement these 1115 waivers under Medi-Cal, and then through that single contracting with the community care hub, we'd have access to a range of services that are covered under the 1115 waiver. I want to note that California, although they have an existing 1115 waiver, they're also looking to make changes to that and enhance their existing waiver. And so you should be following that closely. One of the things that they're proposing is a community health worker benefit, and that community health worker benefit will could potentially provide a pathway for hospitals to have additional supports for Medicaid beneficiaries using community health worker labor that would be reimbursable. But that additional 1115 waiver is not yet approved, so you should be tracking that so that you know once that is approved, additional services that could be leveraged to facilitate transitions. Next slide. In Massachusetts, in their 1115 demonstration waiver, they also include housing supports, case management, outreach and education, and nutrition sustaining supports. So in that market, the overlay, the matching would be people that screen positive for food insecurity. And now in a state like Massachusetts that has nutrition sustaining supports as a 1115 waiver benefit, then that could become the intervention for that person who had a positive screen that you're reporting as part of your requirements, but also as part of your discharge plan and establishing a safe discharge, you'd be leveraging these 1115 waiver benefits to provide those additional supports, such as pre-procedure and post-hospitalization care, housing supports, and case management. I'll give you an example. I was working with a site and they had a person who had a history of homelessness who needed a surgical procedure. And they did not feel that it was going to be safe to do that procedure. But like in a state like Massachusetts, there could be these pre-procedure supports, then a planned admission for that procedure, and then post-hospitalization care. So you could see how that entire episode of care would be better supported for a person at risk if we leverage these types of flexibilities. For states that don't yet have an 1115 waiver or another benefit that I'm going to talk about later called in lieu of services, you may want to talk to your states about the potential impact of not having these tools on hospitals, because a big part of the 1115 waiver and the other benefit called in lieu of services is the fact that it has to be cost effective, and cost effective usually looks at the impact on these benefits on reducing unnecessary admissions and readmissions. Michigan is another state where there's a range of support services to provide housing security and stabilization. Things such as security deposits for persons who require security deposit in order to establish housing. Also things such as utilities and other essential furnishings. In my work with hospitals, I hear quite frequently persons that are sent to emergency departments for quote unquote social admissions because they have, utilities, but they're on oxygen and they can't remain in their home if the power is out, if they're oxygen dependent. Those types of things where we could leverage these waivers to then facilitate that person moving from your emergency department back to their community as fast as possible when they have Medicaid as their primary insurance, and now they're sent to the hospital because of factors like their utilities are out, but they can't be without their utilities in order to sustain their life-saving measures. North Carolina is another state where through their Healthy Opportunities pilot, there's a range of social drivers of health screening and intervention such as housing and nutrition, intervention to address interpersonal violence and transportation. You may see right off the bat how that matches exactly to the CMS screening requirements for hospitals, where from a hospital in North Carolina, I'm required under the inpatient prospective payment system rules screen for housing, nutrition, interpersonal violence, transportation, utilities. And now under the Medicaid 1115 waiver demonstration, we can address those needs for the Medicaid population. Next slide. Separate from the 1115 waiver process, CMS, the Centers for Medicare and Medicaid Services, have rolled out another way that states can provide innovation under the Medicaid program to address health-related social needs. And that's under something called in lieu of services, or ILOS, which is another way that is commonly referred to. And states under the Medicaid program and Medicaid managed care plans, they'll have additional flexibility to propose substitutes for services or settings to cover services under their state plan as an in lieu of. So the way to think about that is, if I'm state Medicaid, if I cover a service such as housing instability as an in lieu of service, there is an expectation that there will be a reduction in other services. So I'll provide housing supports in lieu of what would happen if I don't have the housing supports. So that the same example of a person who has a history of homelessness and now is having repeat admissions to the hospital. If I'm able to stabilize their housing, then that may prevent unnecessary hospitalizations. So that additional housing expense in lieu of additional admissions is oftentimes a more cost-effective way to service the needs of the Medicaid population. And CMS is creating the pathway for states under this in lieu of service flexibility to add those benefits. So if you're in this, or if you or your hospital, or oftentimes the hospital association in a particular state may be in conversation with Medicaid about in lieu of service. This is a hot topic in the Medicaid world, and making the case of the need for these services such as housing and nutrition supports as an in lieu of service benefit, and how it can potentially support hospitals to address the needs of the Medicaid population as we're ramping up screening, is a key way to help move or advocate for expanded use of in lieu of services. So as a specific way to address the impact on hospitals for unnecessary admissions and readmissions. The in lieu of service, the third bullet there, talks about it does also have a requirement for cost effectiveness. So as states are thinking about proposing in lieu of services, they have to also propose how those in lieu of services will be cost effective. Cost effectiveness means that by paying for that in lieu of service as a Medicaid benefit, that there will be a high likelihood that there will be a reduction in the total cost for Medicaid beneficiaries. And oftentimes states propose in lieu of services with the expectation that the provision of the in lieu of service will lead to a reduction in unnecessary hospitalizations, a reduction in unnecessary ED visits, and a reduction in readmissions. And so since that is oftentimes the proposed way to create cost effectiveness, it's very important to get input from hospitals of what are the types of services that you think will lead to improved service delivery to the Medicaid population that will lead to reductions in utilization for the Medicaid population. Your data around screening for health-related social needs, the positive rate, the types of needs, all could be leveraged as part of a discussions with Medicaid for the creation of either 1115 waiver or in lieu of service benefits. So that data is essential for states that are considering this. A memo went out to all state Medicaid directors, encouraging them to consider leveraging in lieu of services as a way to provide expanded health-related social needs to the priority population of Medicaid beneficiaries. And there's been multiple webinars for Medicaid directors, and many states, just like states that are implementing 1115 waivers, many states are considering the in lieu of service. Next slide. These next two slides, I'm at time, so I ran over. These next two slides highlight under in lieu of services, things that the Centers for Medicare and Medicaid Services have sent to states saying that they are eligible for coverage under in lieu of services. A full list is at the link. This list was just updated in November of 2023. You see a range of housing supports under in lieu of services or 1115 waivers is allowable expenses. Next slide. This next slide speaks about food insecurity. So there's a range of food insecurity options that are available. Next slide. So through this strengthening of partnerships between hospitals and community-based organizations, just once last two slides, just wanted to point out that it really is a process of blending and braiding. We obviously won't have all of our discharges that are Medicare eligible. Not all of our discharges will be Medicaid eligible, but to the extent when they have Medicare, we have resources to address those health-related social needs through Part B. When they have Medicaid, leveraging in lieu of services or 1115 waiver and other state plan authorities is another pathway. And then there's other revenue streams because the expectation is that we will blend and braid multiple resources to address the needs of the population. And all of these options will be available to your case management and discharge planning team so they can best meet the needs of the population as we're ramping up screening. Then the last slide is a decision tree. So from left to right, where patients that are having a positive screen, whether they in the middle, Medicare, fee-for-service, or dual eligible with Medicare as a primary payer. We would be leveraging those Part B benefits, such as community health integration, principal-less navigation, in partnership with those outpatient providers or a hospital-owned practice. Medicaid, middle bullet, is looking at additional flexibilities under 1115 waiver or in lieu of service. And then Medicare Advantage, there's additional flexibility on something called special supplemental benefits for the chronically ill. And so there now, with all of this additional flexibility and payment pathways for addressing health-related social needs, it gives a pathway to address the needs as hospitals are ramping up screening and partnering with community-based organizations that can help implement these things in a sustainable manner, leveraging blending and braided funding strategy.